Afternoon. My name is Janie Gordon. I'm with the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I'd like to welcome you to today's presentation, our February Public Health Practice Grand Rounds on Intimate Partner Violence and Sexual and Reproductive Health. I have a few announcements before we get started. For people who are watching online, please check out our archive Grand Rounds and other online trainings. Our next Grand Rounds will be March 19th, and there will be information on the topic available on our website soon. If you're watching online, you can email a question for today's presenters by simply clicking on the link, or you can send your email to maphtc@jhsph.edu. With that, we're ready for today's presentation on intimate partner violence and sexual and reproductive health. And I'd like to introduce today's speakers who each bring a wealth of experience and wisdom on this topic. So we're really thrilled to have them. Michelle Decker, SED, MPH, is trained as a social epidemiologist with expertise in gender-based violence. She is Associate Professor of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health, where she also directs the Women's Health and Rights Program of the Center for Public Health and Human Rights. She brings over a decade of research and programmatic experience in gender-based violence prevention and intervention, as well as its impact on sexual health and HIV risk behavior and infection. This work spans general populations and highly marginalized groups, including youth and those involved in sex trade and trafficking or sexual exploitation. Her work includes the development and evaluation of clinic-based interventions to reduce violence and mitigate its health impact among family planning patients and for high-risk women. Also, a community-based model to support survivors of violence, including trafficking at the Thai-Burma border, as well as primary prevention interventions that harness athletic coaches as agents of change to promote equitable gender norms and reduce violence perpetration. She serves as an advisor to WHO, UNFPA, USAID, Futures Without Violence, and the National Resource Center for Domestic Violence on these topics. Our second speaker, Janice Miller, MSW, LCSWC, has worked with victims of sexual assault and intimate partner violence for more than 2 decades. She is Director of Client Services for the House of Ruth, Maryland, an intimate partner violence center which has helped thousands of battered women and their children find safety and security. As director, she oversees core programs such as the Contact Center, which includes 24-hour hotline and outreach to victims referred after a police-involved incidents, the Client Services Coordinators, who provide individualized one-stop service coordination for all D/IPV clients, the Bilingual Client Services Coordination Program, Adelante Familia, and the Residential Services Program, which includes temporary hotel placements, an 84-bed emergency and transitional housing program, and an innovative community-based transitional housing program that she developed. Ms. Miller's strength lies in developing programs that seek to maximize client strengths and ownership of their potential while providing new paths to success. Some of Ms. Miller's achievements include presenting on an original residential continuum concept at the 2006 conference for the National Coalition Against Domestic Violence, participating in the City of Baltimore's committee to develop the 10-year plan to end homelessness in 2007 and 2012, presenting at the World Conference of Women's Shelters on the unique on-site health suite partnership with Johns Hopkins School of Nursing in 2012, and participating in the 2013 think tank on innovative housing solutions. hosted by the National Resource Center on Domestic Violence. She has consulted for other domestic violence service providers on setting up both community-based transitional housing programs and on-site healthcare services. So with that, we'll welcome our two speakers. Dr. Decker will speak first and then pass the baton to Ms. Miller, and then we'll have Q&A. Michelle?
Great. Wonderful. Well, thank you so much for that great introduction, and I'm really thrilled to be here today, really in this example of sort of research to practice. What I'm going to do is sort of really start off giving you a sense of some of the epidemiology, some of the national data on intimate partner violence, how it affects sexual and reproductive health, as well as tell a little bit about what are some of the leading frameworks for health-based responses to intimate partner violence. How can we harness our knowledge of the prevalence and impact of violence to really enact change for our patients, whether we're seeing them clinically or in community-based settings, et cetera. And then we'll hear about the work of House of Ruth, which is just incredible and a beautiful sort of presentation bringing these two elements together. So what I want to start off with is just to bring us back to some of the surveillance and data in terms of intimate partner violence among women in the United States. So this is very recent data from the CDC, launched the National Intimate Partner and Sexual Violence Survey. This is some of our first national data in over 20 years, so it was really exciting to see this come out. And what I want to draw your attention to is really the prevalence here. This is partner violence perpetrated solely in partner relationships. So you can see rape, sexual violence is about 9% prevalence across the lifetime. Physical violence, 32%, 1 in 3, right? And then when we group people, when we say, is anyone exposed to rape, sexual violence, and or stalking, it gets up to about 35%. So what we're really talking about is about 1 in 3 women in the United States in her lifetime experiencing intimate partner violence. So that's from a marital partner, from a dating partner, someone they may or may not be living with. And then this last row here is with IPV-related impact. So what does this mean? You can see at the bottom that includes being fearful, concerned for safety, needing health care, having an injury, a whole host of sort of services. I wanted to really present this, and I haven't shown the men's data, but what I do want to highlight, and I'll give you a little bit of a sense of how the burden to women differs from that of men. What we do see is fairly comparable prevalence estimates in terms of physical violence and intimate partner relationships for men and women. Where we see differences are in sexual violence, in the burden of sexual intimate partner violence, much greater for women rather relative to men. And we also see in terms of the impact, the IPV-related impact, it's really concentrated among women, right? So here you see 28% are having an impact. For men, it is much less so. So in large part, women remain the focal point for prevention, for intervention in terms of intimate partner violence. I wanted to show this also from the CDC and the NISVIS. This illustrates intimate partner violence really in the life course. So when we think about partners and partner violence, we're often thinking about adult women. And what I really want to call your attention to here is that the age at first IPV experience among those that were exposed is actually in the adolescent years and the young adult years. So when we're talking about partner violence, this is primarily an issue for adolescents and for young adult women. We certainly see older women experiencing partner violence and potentially sustained over time. But when we're thinking about our other types of clinical services, if we're working with adolescents or young adults clinically, this is a primary issue that we need to really have at the forefront of our minds. I raise this only because it tends to be surprising to people, and so I want to make sure you're up on the latest, really the latest surveillance here. One last piece that's a little closer to home in terms of Maryland is a really nice study that was done, and we're so thankful to Diana Chang and Isabel Huron at the State Health Department, really teasing out the leading causes of pregnancy-associated death among women in Maryland. And this came out just a couple of years ago. And what you see here and what is surprising to many people is that homicide is the leading cause of death, pregnancy-associated death among women in Maryland. Of this, intimate partners are responsible for just over half of those homicides. It's really actually very likely to be an underestimate when you consider that these intimate partners were limited to those that were married to, living with, or estranged from a spouse or a current or former cohabitating partner. So setting aside dating relationships that may not have gotten to the level of cohabitation or marriage, right? So this is a surprise again to many people and gives us a sense of what the severity of the violence that we're seeing really is. And finally, backing up again to the national data in terms of homicide trends. So again, fairly recent data from the United States. And what we see here is men are, by and large, the primary victims of homicide, right? So the burden of homicide is concentrated among men. So you see this over 75% of all homicides are to men, with 23% to women. But where we see the difference, and where I mentioned earlier as well, is that when we look at intimate partner homicides, this is really where we see the burden to women. So this is, again, where we're seeing the greatest severity in terms of violence. So what does this mean for health? I'll just give you a couple of illustrations here. These are some older data, but from the Youth Risk Behavior Survey, a nice representative survey of adolescents that are in schools. And what we see here is a really striking relationship of teen dating violence, physical or sexual teen dating violence, with those that are experiencing violence in the blue there. 31% of those had also reported a pregnancy during their life as an adolescent, right? And that's compared to just 13% of those that hadn't experienced teen dating violence. So we see patterns of violence and teen pregnancy, unintended pregnancy, contraceptive non-use, condom non-use, all kinds of dimensions of sexual and reproductive health, primarily for adolescents as well as young adults. And this is also just another illustration, again, from the Youth Risk Behavior Survey, showing the disparity in STI and HIV diagnosis based on experiences of physical and sexual dating violence. So again, you see about a 2.5-fold increased risk to those that have experienced dating violence. Again, these are just examples. What we have seen over time in the US and in other settings as well is actually that intimate partner violence is a risk factor for incident STI and HIV infection. We only have a couple of incidents, especially for HIV is hard to ascertain in populations, particularly where the prevalence is low. But where we have been able to study that, we're getting a little bit of clarity on the causal nature of this, right? When we look at a cross-sectional study, we never are certain, well, did the violence precede the STI or the HIV, or was it a consequence? And I just raised this to share the broader research is really telling us that there is a causal relationship in many places in terms of violence actually being a risk factor for acquisition. So another element that I want to raise your attention to is this aspect, reproductive coercion. This is a term and a concept that has really emerged in the past 5 or 8 years, I would say, drawing from some qualitative research. We really set out to understand, well, why are we seeing these greater levels of teen pregnancy and STI and HIV to women that have experienced partner violence? Interestingly enough, what we found was that actually, in many cases, partners were very actively sabotaging contraception. So, flushing birth control pills, refusing to wear condoms, poking holes in condoms, all kinds of other acts of sabotage, as well as really pressuring women to become pregnant. If you don't become pregnant, maybe I'll leave you, kind of thing. So these are some of the elements that we heard. We were very surprised by this, let me say. We looked at those patterns of violence and adolescent pregnancy and STI and HIV, and we thought, oh, maybe it's an access to healthcare issue. Maybe there's some sort of contraceptive non-use kind of going on. So when we actually learned that in some cases it's very active on the part of male partners promoting these at times unintended pregnancies, it was a real aha moment for researchers and also for practitioners and clinicians in the field saying, oh my gosh, we've got to be doing a better job of anticipating this, identifying it, and providing some harm reduction around these elements. So that brings me to partner violence screening. As many of you, particularly that are providing clinical services, are well aware, screening for intimate partner violence has been one of probably the most recommended healthcare interventions over the past 20 or 30 years, recognizing the greater health burden to those that have experienced partner violence. So we saw these health patterns and we said, oh, we need to be doing a better job of screening and identifying these victims so that we can refer them to support services. Recommended by major professional organizations, many of you are well aware, for example, ACOG and many others. The U.S. Preventive Services Task Force took this question on. Should we be screening? Is it useful to screen for violence? In 2004, the review actually found insufficient evidence for screening. The randomized control trials were not at the quality, and the duration of the follow-up was limited. There were a lot of issues. There were a lot of challenges in partner violence research. We won't get into that today, but just to say, many of you may be very familiar that in 2004, the review found insufficient evidence. And then a re-review that was undertaken about 10 years later and came out in 2013 actually supported screening. So we did and do now have evidence to suggest that screening is actually efficacious in terms of identifying victims and referring them to support services. As many of you are aware, screening has been recommended in the Iowa Consensus Report, Clinical Preventive Services for Women, and of course incorporated into the Affordable Care Act. But what does this look like and what should it look like? This is really sort of the heart of what we really want to share today in terms of a clinical response to violence. And this is the concept of really a paradigm shift, right? So typically when we're screening in a clinical setting, what we want to do most is identify the people that are at risk or have the outcome we're concerned about so that we can treat them. What we have learned over time in working with victims of violence, working with clinicians, working with support providers is that the screening goals in a clinical encounter around violence screening are really much more so around the provision of information and support. So validating experiences as well as providing support without disclosure, making resources about partner violence support available to everyone, and understanding women's decisions not to disclose something that is potentially very stigmatized, something that is potentially very scary. They may not be ready to disclose in that moment. So this is a real shift. When we started the screening work way back when, the goal was to get women to disclose their experiences of violence and get them connected with resources. So I can't emphasize this enough. As we're mounting a healthcare response to partner violence, we want to screen for the purpose of providing that information. Maybe they'll disclose, right? And we can have a conversation in that moment. But even if you think that that person isn't going to disclose in that moment, provide those resources, get those resources out there because those are the ways in which women can get connected to counseling, support services, shelter if they need it, safety planning, etc. And we'll hear about that from Janice in just a minute. I included a couple of quotes on this topic, really to hammer this point home for the providers that are out there in our audience today. So these are quotes from, this is some focus groups and interviews that we did with battered women around understanding what's happening in clinical encounters around violence. So this first participant describes, well, sometimes you see a poster up and you might not say anything that time, but then you remember that you saw something and you might go back. She's talking about this concept, planting a seed of starting this process of thinking about disclosing. And the second one explains, you want them to know the truth, but you're too scared to tell them. You want them to read your mind, and they can't, right? So this is, again, affirming this concept. Get those resources out. Use those clinical settings as an opportunity to share information about the National Domestic Violence Hotline, about the House of Ruth services. These are ways that we can really get people connected to care. I want to tell you a little bit about an enhanced IPV screening model in family planning clinics. This is the Project to Connect model. It really builds on this concept of this paradigm shift in terms of screening. And really the process here is very much a normalized conversational screening approach that really integrates discussion of violence within the clinical visit. And I'll give you some examples of how we're doing that. The goal is to raise awareness about abuse, including reproductive coercion, connecting women with services for those that need them, and again, sort of planting the seed, starting to get people thinking about, maybe I am in an abusive relationship. Maybe this isn't for me. Maybe I should start to think about calling House of Ruth or calling the Domestic Violence Hotline. And finally, reproductive health harm reduction. So providing pregnancy prevention methods that are not reliant on partner cooperation. So intrauterine devices, long-acting reversible contraceptives. The other key element of this is systems change, right? So historically, the focus on screening in the healthcare setting has been one of screen, and what we haven't done quite so well with is telling providers what to do with a positive screen, right? So this model is one that brings in these connections with domestic violence providers so that when clinicians are in a position of identifying somebody that is experiencing abuse, they know exactly what to do. In fact, maybe they've met Janice or somebody on her team and can say, look, let me place a phone call for you right now. Let me provide you an opportunity instead of just, here's a pamphlet, here's a way for you to get connected with care right away. That builds provider confidence, and that is a systems change that enhances our ability to scale up screening. So this is just, you can Google Project Connect. This is a partnership with Futures Without Violence. And you'll see this on their website. But I want to really highlight, this is a quote from the website, but I think it's an important one. This provider talks about this Project Connect model has really changed her approach to public health. I see the connections, and I see how violence left unaddressed undermines each new effort to promote health. She's telling that violence isn't a safety checkbox on an intake form anymore. And I'm wondering, how can violence be effectively addressed? Thank you for this mindset. Thank you for this paradigm shift. So a couple of examples from our safety cards, and I'll show you at the end how you can order these from Futures Without Violence if you are thinking about bringing these into your clinical practice. These are very focused on family planning settings. So again, when we're integrating this conversationally into the clinical screening, into the clinical visit, it's, is my partner messing with my birth control? Is my partner making me have sex when I don't want to? Any of these elements are really intended to help people raise awareness about abuse. This is a pregnancy wheel here, and obviously something that is used by OBs all the time. And this one, orderable again from Futures Without Violence, builds in reminders about domestic violence screening through the pregnancy experience. And finally, this again gives providers some language to talk about experiences of abuse. So the top, I don't know how well you can see this, but it says, I'm so sorry that this happened to you. You didn't deserve that. No one deserved this. Just examples of supportive, validating language that we can work into our conversations when we encounter a survivor. So many of you are wondering, well, where is this getting us, right? So what would happen if we were to implement this, right? So these are some results from our pilot trial. This was 4 clinics in a pilot clinic in Northern California after plus a randomized controlled trial. And we implemented this intervention and found that for women that had been experiencing partner violence, women that were in the intervention arm had a reduction in pregnancy coercion relative to the control group, which was really heartening. This is the first real effort to address reproductive coercion in the healthcare setting. And very interestingly, this was sort of a post-hoc finding, not one of our primary analyses, but women that were experiencing the intervention told us they were more likely to end a relationship because it felt unhealthy or unsafe. So this is telling us that screening in the healthcare setting might actually be planting a little seed for people that may be in relationships that are starting to feel abusive, starting to feel controlling, etc. We thought this was just incredibly heartening, and the larger trial is wrapping up now in Pennsylvania that brings in a larger number of women, of course, and a longer follow-up. So I'll have to come back and share those results when they're ready as well, but just to give you a sense of that. And I want to pass things on to Janice, but before I do want to just mention a little bit of work that we're doing really to bring this model and to bring these concepts of screening and validation in connection with services to a very high-risk population, and one that we don't talk about nearly enough in public health, and that is women that are involved in the sex trade, trafficking, and sexual exploitation. So many of you are thinking, oh, sex work, this is
a very high-risk population. We often think about this population solely from an infectious disease standpoint, right? STI and HIV, back to the 1800s, right? And what we're increasingly seeing globally, domestically, right here in Baltimore, is that women that are involved in sex work in any of these capacities are experiencing significant levels of violence from partners, from intimate partners, for one, and also clients, pimps, and others that are exploiting, perpetrating physical and sexual violence against them. This is interesting because the prevention and the public health infrastructure for this population is historically and today one of HIV and STI prevention.
And the links with the violence community haven't been as established. And so what we're doing now, and we're really thankful to the Hopkins Center for AIDS Research in funding this intervention development, is we have a community-based participatory research and intervention sort of development program underway, bringing in our colleagues from House of Ruth and others that are providing direct services, street outreach to women that are involved in sex work in any of these capacities. And we're really beginning to shape out a model that's going to provide violence support, again, and connection to services, connection to resources for women that are in the sex trade. Again, we're really excited about this. This is under development, but I really did want to make our viewers aware really of what we're now really recognizing in terms of both intimate partner violence and violence from other individuals for this population of women that are involved in sex trade or trafficking. And before I close and pass things over to Janice, I want to make you aware of just a couple of resources, and Janice will tell you a lot more. But the National Domestic Violence Hotline is right here, and then I also want to make you aware that you can order safety cards and support resources at Futures Without Violence. Many of them are oriented again to the family planning clinic setting, as well as other marginalized populations, and there's some tools in terms of training for providers as well. And I'd be happy to talk with any of you about any of this, and my email is in the very beginning of these slides, so thank you, and take questions at the end. Thanks.
Thank you, Michelle, and thank you all for having me here today. I just have to find my slides.
Just want to close this one. And it's right here. And then where's the slide view? Where's the slideshow? No? Oh, here.
Yeah.
Okay, so you can just put from
Broadcast.
current slide.
Do you want to broadcast or from?
I don't know why this is so hinky that I can never get it. I think actually, let's go to
From current slide. Ah, there you go. There we go. There we go. So again, thank you for having me here today to speak to you. I'm going to talk to you a little bit about the House of Ruth and some of the innovations that we're putting into place to intervene in the issue of intimate partner violence. The House of Ruth Maryland is the largest provider in Maryland of IPV services. And I think when people think of the House of Ruth, mostly they think of shelter. But the House of Ruth is really a much larger provider of services, and we serve multiple jurisdictions. We are in Baltimore City, serve Baltimore County, Prince George's County, and Montgomery County, and we have offices in all of those locations. Over 14,000 victims were served by the House of Ruth Maryland last year in fiscal year 2013, and we have multiple access points for folks to get to us. They come to us through our 24-hour hotline. We have one hotline that serves all of those locations, so you don't have to remember if you're in Montgomery County to call somewhere else. You just call the one hotline number, you get to the House of Ruth Maryland. We have walk-in sites in the communities where our victims are most likely to be, and in the courthouses, because we know that a lot of victims come in to get those protective and peace orders. We have a court-ordered entry point for abusers through the abuse intervention programs, Gateway and Si Puedo, and we do active outreach to recent victims after they've been involved in an incident. 516 adults and children used our 84-bed emergency shelter last year. That's approximately 300 women, and then the 216 or so is the children who used our services. Our average length of stay is about 45 days, but women stay as little as a day. They may stay as long as 90 days or longer. Our transitional housing program has the option for folks to stay up to 2 years. 100% of those clients receive service coordination. They receive that individual one-on-one attention with someone who partners with the victim to determine what works best for them in their situation and how to help them get to that place. Because the House of Ruth has a number of services, the service coordinator helps them access all of those services in-house, but it also helps them to access the services in the community that are going to be most beneficial to them. We also have a developmental preschool in our shelter, which is very unique, and it's a licensed daycare as well. Women can apply for the daycare vouchers through Department of Social Services and then have them transferred. It's a lot easier to transfer vouchers than it is to actually get them. So if we can create that stability while you're in the shelter program and then help you move on, you can keep that stability out in the community. And you're going to hear me say a lot about stability because that is a key to keeping women safe in an intimate partner violence relationship. 172 women and children received health care services in our on-site health clinic during fiscal year 13. And I'm going to talk a little bit more about them in a different slide, so I don't want to go too much into that right now. We also provide community transitional housing through our Safe Home Strong communities. We do individual, group, and family counseling. We have a very innovative counseling program that's actually a Krieger-funded initiative that is family dinner. The moms and the kids come together, and they eat dinner together, and then they break out into counseling groups. And part of that is to try to recreate some of the normalcy that's lost in a violent relationship, in a violent home. We have specialized victim services that provide culturally and linguistically specific services through our Adelante Familia program and through our Si Puedo program. That's the abuse side of the service. And then through our service coordination program, again, that's specialized for each victim as they come through. There's no set way that you work with a victim of intimate partner violence. And I think that's a real key when you're trying to do an intervention in this population. You have to meet the individual where they're at because there's no cookie cutter approach as to how you intervene in that. Think about how every relationship you've been in has been different. There are some similarities, but mostly your interaction with that other person is different. And so that's the same thing that's true for each of these victims in the relationship. Our legal clinic has 17 attorneys. We do protective orders, we do divorce and custody, and over the last year we've represented 1,320 clients in protective order and related proceedings and 150 clients in divorce and custody. And then we have nationally recognized programs such as our legal clinic, such as the Safe Homes program, and such as our AIP programs, the Gateway Project, which has a curriculum specifically designed for young African American males in urban settings, and Si Puedo, which focuses primarily on Spanish-speaking immigrants to this country. So you've heard a lot from Michelle, and you'll hear more from me about this idea of planting the seed. Because in intimate partner violence, the abusive partner uses coercion and force to control the victim. And the key to disrupting that cycle of intimate partner violence is to take the control away from the abusive partner. And so how do you do that? Well, first thing you have to do is raise awareness. You have to get the information to the victim in a way that they can envision themselves living a different kind of life, not being controlled by their partner, having a healthier relationship with their partner. This is a possibility in their world. So mandatory services for victims don't work. Because if you mandate that everybody go to a support group or you mandate that everybody must be in bed by a certain time in the shelter, it takes the control and dignity away from the victim. In a public health setting, in a clinical setting, if you mandate that every victim who comes in, you must report the abuse to the authorities or you must engage in getting a protective order, you're taking away the control and dignity from the victim. They're not going to come to you. Word of mouth will spread. Folks will go find somewhere else or they just won't seek those services and they won't get the necessary information and help that they need in order to ultimately break free of the cycle of violence. So at the House of Ruth, we try to increase safety through improving that awareness and creating more basic needs stability in the lives of the victims that come to us. Because as you know, if you can control your income, if you have enough food to eat, if you are able to control your health situation, if you have somewhere safe to lay your head at night, you have more options than if you have to rely on someone else to provide those things for you. So the first program I want to talk about is the Lethality Assessment Project. This is a joint partnership with the Baltimore City Police Department. It's taken us 2 years to implement this throughout the entire city of Baltimore and all the different police jurisdictions. Because we recognize that victims don't seek services because they don't know they're available or they don't know that they're being abused, when an incident occurs and the police come out to the house, the police implement the Jackie Campbell's danger assessment scale with them, and then the police offer the victim the opportunity to take them to the shelter. Very few take the police up on that at the time. But they take those reports and they turn them into the House of Ruth. We take the reports and we make a call out to each of those victims. And if we can't get through to them, we refer it over to the the Family Crimes Unit in the police department, and they will do a personal follow-up with the victim in the community. But at the time that we call out, all we're doing is saying, hi, we see that there was an incident. We'd like to talk to you about what services may be available to you. We'd like to talk about some safety planning. And a lot of times victims will say, this was a misunderstanding. He's promised to change. It's all going to be okay. And he's left, or I'm leaving, and I don't really want to talk to you today. We said, that's fine. We just want to let you know what's available, tell them about our services. And then what's really interesting is that about 6 weeks later, victims call us back. And I've been on the hotline. A victim will say to me, somebody called me and told me about how I could get custody of my kids. I'd like to know more about that. I thought it was going to work out. Now I see the violence is starting again. I'd like to hear more about that. And so by planting that seed at the beginning in a very low push, we're not trying to aggressively sell you on anything. It opens the door for the victim to, much like those posters in the Project Connect, it opens the door for the folks to be able to just come back to us on their own time, in their own place, and know it's safe to talk about, and really helps to then get them in the door for that safety planning. In 2013, we recorded 1,069 instances of outreach to victims. Incidentally, that's only about 50% of the reports that came in Baltimore City. 259 instances of civil legal advocacy and 46 instances of criminal court accompaniment. The other thing that this project has created is this most dangerous offender list. And, what's really great about this list is I've managed to identify individuals who show up again and again and again as very dangerous people to the people that they're supposed to love. And on this, so that if the police go out to a call and see that the victim is on this list, they take that call, that visit, much more seriously, because they realize that she's at a much more heightened risk for death. And the same thing with if the abuser's name is on there, because he may have moved on and found someone new to date, new to abuse, but his behavior is not likely to change from victim to victim. And so they recognize and they try to work together to try to get him off the street. The second program I want to talk to you about is the Shelter Health Clinic, because we know that untreated health conditions interfere with safety and stability. If you can't work, if you constantly need help with your basic daily living, you need someone to rely on, then you're going to more likely stay in the relationship than if you can get the treatment somewhere else and be able to leave. So in 1998, when we opened our new shelter, with the Johns Hopkins School of Nursing, we set up an on-site health clinic. It's 2 rooms in the building. The Johns Hopkins nurses come out and provide services at the clinic. Healthcare for the Homeless joined us in 2011 to provide pediatric nurse practitioner services. And in 2013, the clinic was designated a Title X site and implemented the Project Connect protocol. So women now have access to good reproductive planning and information, as well as the general health services that are provided. And so in this last year, 96 women, 76 children visited the clinic, and you can see that they received a variety of different services, including injury prevention, chronic health condition counseling, family planning, and most, help assessing getting the primary care physician in place. The Shelter Health Clinic partnership is a very good way of, again, taking the control away from the abusive partner and putting the control back in the hands of the victim. He has kept her from getting health care. He has kept her from getting her medication, or he sold her medication on her. He has kept her from being able to address her own physical needs, knowing that that's going to keep her in the relationship. And a lot of times the women in the shelter will come to the health clinic not for themselves, but because their children need medical care, and then the nurses will then draw them into a discussion. And so it's an opportunity to help get them stable in their own situation so they don't have to go back to that abuser. The third innovative program that we have is the Safe Home Strong Communities program. So even though we have an 84-bed shelter, we still turn away 2 women for every woman who comes into shelter. 2 women for every woman who comes into shelter. So we decided this was not acceptable. It's not okay to say to someone, I'm sorry, you can't come in. We don't know what happened to you. So we wanted to figure out what are some other housing possibilities that we could do. So we set up a continuum of residential services, and on the far end of the services is this Safe Home Strong Communities program. In 2009, through Recovery Act funding, we wanted to figure out a way to help women bypass the shelter system completely. How can we get women either in shelter for a very brief period of time, week or 2, and back into the community, or bypass it completely and go straight from the abusive home and into a community home? And with the help of 6 months of step-down rent assistance and a dedicated service coordinator, we've set up this Safe Home Strong Communities program. The beauty of this program is that you as the victim are allowed to live the way that you want to live. There is no curfew. There is no folks trying to tell you how to do whatever you're going to do. You can live in the community that you want to live in. You can establish the routes to school, to work, to the store, all on your own. And you have somebody coming to you to help you figure out how to do that. In addition, we all know that when you move in somewhere new, you have all these unexpected expenses that you didn't really think about. I don't have any ketchup. I didn't realize that I had to pay for, extra travel money. I missed work because I was moving or my child was sick. And so those 6 months of rent assistance, which is only $1,500 to $2,000 over 6 months, is really there as a stopgap in the budget to help the woman get completely stable before we back out, and then she lives on her own. And 76% of the folks that we've placed in this program have been able to assume the rent at the time of exit from that 6 months of service coordination. That's compared to an average that has stayed stagnant over the past 15 years of 34% of shelter clients. Only 34% of clients who go through shelter move out and become permanently housed in the community at exit. 76% of these clients are able to do that. So that's why we feel like this is an innovative way. And if you can live on your own, it's a lot harder for the abusive partner to control you. If you control your own assets, if you control your own comings and goings, it's a lot harder for that abusive partner to control you. It's not impossible, because we have some very clever folks out there who want to control other people, but it is a lot harder. So in the field of public health, in the field of IPV, we have to get away from this idea of reactive services. It's not enough for us to say, women are fleeing their homes, let's set up a shelter. Women need relief from abuse, let's set up a protective order. What we want to do is we want to get ahead of the tide. We want to go upstream and figure out how to stop it at its source. How do we get in there and short circuit this ability of the abuser to control the victim? How do we plant the seed that there's another option out there for the victim? All strategies have to be focused on safety. In the late 90s, there was a very well-meaning movement to set up victimless prosecution. Hey, we have a great idea. Why don't we set up a system that says that the prosecutors can go forward without the victims we don't need the victim to testify. We're just going to go forward with it. But what they weren't taking into account is what the potential danger was to the victim in doing that. And also whether or not that's something that respects the inherent dignity in each person to make a decision for themselves about what's best for themselves. So we have to stay away from the idea of mandatory services. We have to stay away from the idea of services that are not focused on the potential consequences for a victim's safety. And we need to really just plant those seeds. What's the awareness? Passing on information to someone, I'm going to reverse what I just said. A mandatory policy that says everyone must pass on information has no safety consequences to the victim. It's just information, particularly if you are passing on that information to people who are victims and non-victims, because how do you know if they're a victim or a non-victim? You're just passing on information. And maybe that non-victim that you passed on the information to knows a victim, and they will pass it on to them. You're planting the seeds in the community. And then it puts the power to act back in the victim's hand. And eventually, what we have learned through some of our programs, they will act. They will act when they see that they have an opportunity to achieve safety. They will see when they have an opportunity to achieve stability. They will act if they know where to go and if they feel like they're not going to be shamed for accessing those services. So if we can combine those awareness and stability building initiatives, then we can prevent the return to abuse solely because she does not want her children to sleep on the street. She has to be able to feed herself and her family. She needs someone to take care of her health-wise. And I think we're on to questions.
Thank you. Before we take questions, there are a couple of housekeeping details. For people watching online, you can click on the link on the screen to email a question, or you can send an email to mapphtc@jhsph.edu, and saying that is sort of a lesson in pronunciation. For people in the live audience, would you please wait until we bring a microphone to you before you ask your question so that the people listening online will be able to hear the question. And also, to people in the live audience, when you leave, if you have not signed in, if you can, there's a sign-in sheet to my right back by the doors. If you could sign that, and there is only the table on the right-hand side, we'd appreciate it. So now we're open to questions, and we'll start with the live audience if there's a question.
Hello, my name is Taiwo Ajao. I'm a student at the School of Nursing. I'm curious to know, from your perspective, what roles media could play in effectively supporting the initiatives that you described today. What are some ways that people who want to bring awareness to the issues through media, what are some of the effective ways you can do that?
Sure. So One Love Foundation has an excellent app that you can download onto your phone, and it allows you to do that danger assessment so you can sort of rate your own relationship. And then the way they've set that app up is that it automatically goes away after you've taken it once. So it's a safety feature as well. So if you think someone's in an abusive relationship, they can take the app and then it goes away. Poof. It's the modern marvels of modern technology. So, I think that developing apps like that, I know Michelle and I have talked about a similar type of app for some of the street workers and women involved in the sex trade. Those are apps that are available that I think provide that safety measure and also are effective in raising awareness. And I think there's lots of potential out there for using social media as a platform for raising awareness, for getting more men involved. 9 out of 10 men are not abusive. I think that statistic gets lost when we start talking about intimate partner violence, and a lot of men start to feel like, you guys all think that we're the bad guys. I mean, we recognize that the majority of men are not abusive partners, so how do we use the media opportunity out there to harness those men and becoming spokespeople saying, hey, it's not okay for abuse, and how do we get them to provide that pressure on their friends, or that planting the seed, well, I don't think that's cool that you talk about women that way. So that's another opportunity.
Yeah. Yeah, no, I think it's a great question. And you know, one of the other things that strikes me, and I guess I was just reading The Sun yesterday, and there was a great piece, and maybe some of you saw it, about a domestic violence incident. And I was so delighted to see quotes in The Sun, in the report on this topic, from the Maryland Network Against Domestic Violence, right? And those quotes were saying in this article, we know that domestic violence affects people across all walks of life, right? And so really when we see media reporting in maybe more of a traditional sense, not so much the social media, that too, but when we see traditional media reporting on gender-based violence, getting some of those quotes, be they from House of Ruth, be they from national or local networks, on really kind of breaking some of the myths that people tend to have about violence, that's a way that we can really harness the media to get some of these messages out around raising awareness. What is violence? What does it look like? And who does it affect?
PhD student at the Johns Hopkins School of Public Health. I thought the discussion about giving people a sense of agency and not doing prescriptive programming as a way to help women start making decisions in their own lives was fascinating. It was actually not something I'd ever thought about. But then I was wondering if there's actually a continuum that you have to be aware of for women who are used to having so much of their lives dictated. There probably has to be some kind of transition before they can make all of their own decisions. And how do you balance letting women make all of their own decisions related to programming with the fact that that might not be something that they've had the opportunity to do in the past?
Yeah, I think that that's a really great and very insightful question, and I think it's something that the service coordinators in particular struggle with on a daily basis, particularly for women who grow up in intergenerational poverty and have a history of interacting with the social services system. They're very much used to having people tell them what to do on a daily basis, and it's, you know, one of the easiest strategies that we use is just silence. It's just waiting. You have to sort of wait people out and wait for them to come up with something. And even if it's a very, very small step, or it seems small to you and I, for example, then you go with that and you reinforce it, and then you show that there are positive consequences to making that step, and then you move on from there. And so the kinds of gains that we talk about with some of the women who are in those roles of intergenerational poverty or have entered into these abusive relationships at such a very young age. If you saw some of the statistics, you know, 11 to 17, you're talking about 11-year-old, you're talking about children who are younger than that who are sexually abused. Those children, when they start to become, you know, sort of responsible for their own lives, you have to look at the gains from where they started, not against the standard that we might consider a successful community member. And so if you can start where that client is at, that individualized basis, then it becomes an easy process to let the victim guide that. And she moves from being the victim then to being the survivor, because she realizes that she does have control over her own life, even if it's just this one little corner of the world.
Yeah, and that's really what I loved about the, I'm going to botch the name, it was the continuum for the housing piece, the where you're gradually getting people off, let's say, sort of off the support that you're giving them in a sense, and really to sort of really get at that concept of, gosh, if you've been in this relationship for so long and had this control taken away for you for so long, it would be really counterintuitive to think that we're going to now just send you right out and you're going to sort of succeed and be able to manage all of that right away. So, you know, to me, what's so exciting and so innovative about that model is that it's very much recognizing that reality, right, and building programming that supports people rather than sets up expectations perhaps that are not just not the reality.
Okay, we have a question online. Do we have figures on the rates of female against female intimate partner violence, and whether that is on the rise in comparison to male against female IPV?
Yeah, that's a really important question. I'm so glad that one of our viewers or listeners raised that. One of the challenges, and I'll be curious, Janice, your experience at House of Ruth, in terms of the national data, one of the challenges is that it historically has not been something that we've had a lot of attention to, I would say, in our national data. So I told you, the NSVIS came out just about a year ago, and previously to that, the next most recent data was from 1998, right? So it's been a while. And So we don't really have a good benchmark necessarily over time, because that wasn't quite on the radar screen the way that it is today in terms of the potential for female-on-female violence. And I would say within the NSVIS, and I'm trying to think if they did those analyses or not, the numbers tend to be small enough such that in a national survey, you don't always have the sample size that you really need to have a stable estimate in terms of that around same-sex relationships and violence within that. So to answer your question very simply, we don't have great national data on that, but I don't know what your experience is in terms of direct services.
Well, the Northwest Network has some very good information out there about rates of same-sex partner violence, and what's really interesting is that the female-on-female violence rates are pretty much parallel to male-on violence rates. So you find about a quarter, about 30% of incidences in those two populations. The rates of male-on-male violence is harder to categorize. I don't think there's been a lot of focus on that, and I don't want to speculate, but it's not too much higher than that. So let's say 30 to 35% in that rate. Male or female on male violence is always lower. It always comes in at like 5 or 10% of those relationships. And what's really interesting to me is that the rates in transgendered individuals are much higher. They're much, like, to me, it's off the charts. It's 50% of those relationships. So you have a 50-50 chance if you're in a relationship as a transgendered individual of being abused. And so I think there's a lot of, obviously, societal norms and community violence that's also incorporated into that piece of it. So I think it's hard to tease out in some of those relationships how much of this is true intimate partner violence versus how much of this is amalgamation of community violence, family violence, and intimate partner violence. Depends on how they do the research out there. But we can say with confidence that the rates on female-to-female violence is about the same as the rates to male-on-female violence.
Okay. There's another question online regarding clinicians and screening for intimate partner violence, and it says that you spoke about the highest incidence being in adolescents and young women, and so at what age and what type of clinician will do this screening? Do pediatricians, internal medicine, family medicine, and at what age?
Yeah, it's a great question, and I should mention, and I didn't do this in the talk, but I should have. That there's been just phenomenal work at the State Health Department to come out with recommendations in terms of a screening tool that can be implemented across all of these settings, and I can make that link available through the website after this discussion. But in terms of, so I would say any clinical group that is seeing large numbers of adolescent women, could be adolescent medicine docs, could be pediatrics for your older populations, general internal medicine, certainly family planning and STD programs, large pockets of adolescent, sort of mid-adolescent, 14, 15 years old is a good time to sort of start this and start implementing it, as well as any other groups that are really seeing large numbers of women. I think in terms of, it's an interesting question. I think in terms of the implementation of this, what we've seen is specific, my experience in terms of the testing and the intervention of various screening protocols has been, we'll test it in the emergency department, we'll test it in family planning clinics, and so forth. And that's really where you see the intervention outcomes are very sort of specialty specific, but if you're thinking about when and where to implement this, again, certainly adolescent medicine, certainly family planning and STD programs, as well as pediatrics for the upper sort of age groups. And I don't know what you...
I think there's great potential to implement in orthopedics and sports medicine. I think that the assumption is that if you're going to a doctor for sports issue, it's an injury related to the sport, but it's a great opportunity because you've got that one-on-one individualized place to ask about the violence that may be going on that may be masked by the sports. And because we know that there's still a great deal of work to do in a lot of sports teams, particularly male sports teams, around the highly aggressive and masculinized behavior of those teams. And we know that women on sports teams tend to date men on sports teams. I think there's a missed opportunity there for those doctors and for orthopedists when they're seeing folks with shoulder injuries or elbow injuries to start to ask those questions about, you know, is something else going on here? Is there an opportunity there? That's a very low-key introduction. You wouldn't necessarily think to ask about intimate partner violence in that venue, but it's a great opportunity because a lot of teenagers use those services.
Yeah, that's great. There's also been a big push, you made me think of it in terms of sort of opportunities, but there's also been a little bit of a push to integrate screening into pediatric clinics for the moms of very young patients, and that's another opportunity to get information out there in terms of getting, you know, posters out and safety cards out and potentially even integrating screening within standard practice.
We should also mention that Project Connect, the other half of Project Connect is an adolescent health program, and part of that is again designed to get at those adolescents in the school systems, in the venues where they happen to be. So while in Maryland the Project Connect model is focused in the reproductive health clinics, there are other jurisdictions that are implementing this adolescent health component.
Any questions from the live audience?
I actually volunteer at the Gateway Project, and I'm very interested in interventions that target the perpetrators of violence. You had talked about how the survivors need to be treated on an individual level, and all these important individual differences. And I'm wondering if that also applies to the perpetrators of violence, and if so, how that may complicate sort of the broad application of interventions that target the perpetrators of violence.
Yeah, that is a great question, and it absolutely applies to the abusers, the perpetrators of violence. If you know, Lisa Nitsch, who is the director over the Gateway Project and the abuse intervention programs, she made this great statement just this morning, which was, if you've ever met the guys in the groups, they are miserable. They don't like this any more than the victims do. They don't get anything out of being abusive. They are trapped in this relationship where they feel like they are being wronged, and they don't have a lot of the same supports that the victims do. If you're going to do work with men who are perpetrators, you have to go into it with the idea that they don't want to be perpetrators and they have the ability to change. If you don't believe that men can change, you shouldn't be doing the work, because you have to treat them as if they are individuals who want to live a healthier life and just don't know how, and move them toward that path.
Kind of a follow-up to that question. How do men come to the Gateway program? Do they come voluntarily? Is it part of a court order, or how does that work? Or the counseling programs at House of Ruth?
The abuse intervention programs are all court ordered. Occasionally we'll get a man who will seek out voluntary services. That does not happen very often. For the most part, they are court ordered to come, and then there's two stages to the program. There's the accepting that you perpetrated violence stage, and then the second stage group is really focused on the moving forward and how do you continue on with a healthier life.
Okay. I see a question in the audience.
Hi, my name is Sana. I think it's very clear to me that you've been really successful in creating innovative programs and gaining resources for your programs. And I feel like that's not the case for other programs, not just because they don't want to, but because they're so overwhelmed. But I would like to learn more about how you've been so successful in gaining those resources, maybe some advocacy strategies or the messages that you use to talk to funders.
That's a huge question. You know, I wouldn't say that we're not alone. Turnaround has a really great trafficking program running in the city and in the county, and then there's a lot of hospital-based programs that have done some really ingenious things with one or two staff people. So even though the House of Ruth is so huge, we're not alone in the fight against violence. You know, I think that the primary thing that you need is to have a really good articulated vision. Because if you've got a good vision, then you can get people to buy into it. And if you can get people to buy into it, then they will fund the initiative. But then on the other half of that, you've got to be able to have the folks to implement it and be able to provide the feedback back, that data, that outcomes back to say, hey, this really worked. So in the 30 seconds I have to respond to your question, I think that's the way that I would respond, even though we could probably spend a whole hour on that piece of it.
Okay, I have a question online that is regarding the lethality assessment program. What type of response did you receive from the police, administration, and/or officers? Was it favorable, program is helpful, or unfavorable, program is a burden for them?
Well, as you might imagine, anytime you implement something that, so as you might imagine in your own work, whenever you're told you must now do this brand new thing, there's a little bit of resistance on your part to doing the brand new thing. And so there are folks who were resistant to the idea of doing the screen with folks, but we had a lot of buy-in from the top level folks who then, helped to implement it with the rest. And then this collaborative effort between the city and the police and the House of Ruth, and helping people understand why this was a good thing, helped us to be able to successfully implement this program. And the truth is that the police officers were all frustrated as well. Sometimes they go out to a house 3, 4, 7, 12 times, and they start to feel really frustrated. If you can't help them make sense of why the victim doesn't leave, because that's the question on everyone's mind, then it's very hard for them to continue to treat the victim as the victim and not as somehow complicit in the whole relationship. So the Lethality Assessment Project has really been an opportunity for us to collaborate with the police and give them those explanations of how victims act when they are traumatized and how we can better serve victims by doing this outreach activity that we do, and giving the police the option of having somewhere to take the victim when they feel like the victim's life is in danger. So I think overall it's been a very positive program, and at this point no one is looking to try to end it or hoping that the funding will go away for it. They're actively trying to keep this project going because they do see the value in the program.
Any questions from the live audience now? Okay, there's a couple more from online. One is asking about the relationship between homeless women and women who have suffered intimate partner violence, and what percentage of homeless women are victims of domestic violence?
Yeah, that's a great question. We know that these problems of violence and homelessness are obviously very much interwoven in terms of some of the civility issues that you heard from Janice, and just from the data that we have in the world. I'm hesitant to sort of put out a guess in terms of the prevalence. Don't think we have great data on that, but where it has been studied, and this won't surprise you, the prevalence of violence among women that have been or are currently homeless is quite high. And what's also interesting is that there are different reasons, on the path to homelessness or housing instability for men and women. Those are different paths, right? And for women, that path much more frequently includes partner violence than it does for men. So you're seeing certainly the burden there in that population, and you're seeing it as well as potentially along that causal path or reinforcing cycle in many of the ways that you can imagine. And I'm sure you have some thoughts about this as well.
Right, I don't have exact statistics. I know the National Institute of Health put out a wonderful brief recently on the links, causes of homelessness and housing instability, and domestic violence was listed as a key factor, and they showed that when there's a constellation of issues, and domestic violence was in that constellation, then the likelihood of homelessness and housing instability was much higher. The home study, which was done on the West Coast, I want to say Portland, also found the same link between housing instability and domestic violence. What we do know, and again, I don't have any statistics on it, is that for homeless women, the rates of sexual violence are through the roof. And when I say through the roof, I mean they're up there like 80-90% of homeless women have been sexually assaulted. So we do know that the risk of violence, of intimate partner gender-based violence, is much higher for homeless women than it is for the general population of women.
Okay, there's another question online about related to Project Connect and follow-up. In the family planning clinics, do the staff or the provider do follow-up after the visit, is the referral or the information the end?
Yeah, so that's a great question. In terms of the clinical follow-up on anybody that has been diagnosed or identified as in a domestic violence situation, there's no set protocol on that. And part of the model, in truth, is one that empowers clinicians to screen and raise the issues of violence in a way that is comfortable for them and enabling them to do it on a very, very routine basis, and then provide them with the tools to provide the referrals to House of Ruth, to other service providers in other kinds of areas, so that the follow-up that's very specific to domestic violence is really sourced to the experts, right? So for those reasons, we don't ask our clinicians to do that follow-up. I was actually really intrigued to hear about the follow-up that you're doing, Janice, with the police program, the lethality assessment program, and I was thinking, oh, maybe that's something that we might want to think about building in, could be that exchange of information such that an advocate or somebody could actually place that call. To this point, we haven't done that, and we haven't really felt that we needed to. The results are telling us that women are more aware of services and more aware of the types of services that are provided. Again, getting people sort of past this idea that, okay, there are shelters available and maybe that's it. We really feel like this model is telling people, doing a really good job of telling people that beyond shelter, you may or may not need that. There's also counseling and safety planning and other elements that can support safety and promote health and empowerment truly that exist. So really it is merging those systems and, again, sort of taking the follow-up to the domestic violence service providers.
Okay, there's another question online, excuse me, about the prevalence of violence against women by ex-partners, which is something that we see a lot. Watch the 11 o'clock news.
Right.
And what kinds of research or programs, prevention programs, are in place to try to help women who are in that situation?
Mm-hmm. Well, we do know that women who have left a relationship, there's a window after they leave where they are at heightened risk, in particular for lethality. And part of the reason for that is that, again, when you sever the abuser's ability to control the situation, he will escalate to try to reestablish that control. And so if she's left him and he can't woo her back, promise his way back into the relationship, then he's going to escalate to trying to force her back into the relationship or trying to make it so that she can't be in a relationship with anyone else. So, a lot of the studies categorize relationship differently. So it's hard to get a good statistic of strictly from ex-partners versus current partners, because a lot of times they'll say spouse or former spouse, dating partner or former dating partner. And even when you talk to a victim, when she comes into the shelter and you say, is this your boyfriend? She'll say ex-boyfriend. And what she means is, as of today, he is my ex-boyfriend, but it may be that a month later she's back in the relationship with him, or it may be that she's out of the relationship. But it's hard to, like, what point do you say, this is my ex-partner versus my current partner? So are we classifying her as a current partner? Are we classifying her as an ex-partner? Are we talking about people that 3 weeks later it becomes the ex-partner, or is it 3 months later? It's hard, it's easy to say, well, that's my child's father and I haven't been with that person for 4 years. That's clearly an ex-partner, but it's where do you draw the line on the ex part?
Okay, any questions from the live audience? Yes.
Hi, I was wondering, is there any information about services or research related to verbal or mental abuse? So in cases where there wouldn't necessarily be physical, but just, not just, because it's obviously important, but mental or verbal.
Sure, and if you think about domestic violence as an iceberg, what we end up spending most of our time talking about is the part above the water, which is the physical abuse and the threats to kill, because obviously once you're dead, you can't intervene. So we try to focus on that above that, but most of domestic violence is that coercive control, which involves the verbal, it involves the subtle relationship controlling, and that's the under the water part of that iceberg. I don't have any specific statistics about rates of verbal abuse or emotional abuse or mental abuse. Do you?
I don't have any off the top of my head, and I think in part it's been a very challenging area to study when you think about what would constitute, just sort of classifying what would constitute and sort of setting thresholds for patterns, and are things coercive versus, name calling. I mean, so that tends to be a little bit more subjective. I think some of the reason that you see a big focus on physical and sexual violence in the research world are they're a little bit more concrete. I think it's easier for people to sort of say yes or no, I had that experience. And some of the emotional abuse and verbal abuse experiences are a little bit harder to pin down. And we also know that they are so often hand in hand. And I do think that perhaps that has, focused the research as well, sort of on that very tip of the iceberg, knowing that some of those coercive controlling mechanisms, things that are verbal or just emotional kinds of abuses, are very much part and parcel of all of this, and do sort of underlie are below the surface there.
So the Project Connect model, the lethality outreach, those are programs that are really designed to intervene, because it may just be a verbal altercation that the police come out to. It may be that the person who's coming in for her regular family planning visit is being coerced into dropping the birth control method. And she may not realize that those are forms of coercive control, that those could be leading toward this much more serious intervention, much more serious incident. And so the intervention, that planting the seed intervention, is so important, that the more often that we can really get in there and say, this is not a healthy relationship, this is a healthy relationship, and really help people to see that difference, then the more likely we are to be able to prevent them from having to use the shelter, to prevent them from becoming the next statistic, to prevent them from having to give up and disrupt their whole life and then have to rebuild it.
But the services in terms of counseling and sort of hotline and crisis services would be for anyone,
yes.
Right? Okay.
Yes,
just
they're available to everyone.
Janice, you mentioned sports team and sort of the male, often macho kind of norm among sports teams. And I know, Michelle, you didn't speak about this directly, but in the bio that you provided, you talked about work with coaches to change those norms.
Yeah.
Can you talk a little bit about that?
Yeah, I'd be happy to. This is I sort of often talk about that in terms of more primary prevention kinds of elements, but I'm happy to share that Futures Without Violence collaboration with their group and the Coaching Boys into Men model, if people are familiar with that. And essentially this model sort of harnesses athletic coaches as role models that are not parents and not teachers, that have access to youth, right, on a very ongoing basis, establishing these relationships over time. And the Coaching Boys into Men model is one that brings in sort of a, we call it it's a toolbox, and there are a set number of lessons, and the lessons allow sort of coaches to bring in elements of setting gender equity norms, setting examples about respectful behavior, calling out athletes, and observing other kinds of behaviors that are not respectful, so name calling, bragging about sexual experiences, etc., things that ultimately become, bullying or very, very harmful. So coaches really taking that leadership role in setting what to do instead of sort of perpetuating, as so often can happen, what not to do. The other element is also trying to get coaches to engage youth to become sort of better bystanders, right? Many of the sexual violence experiences that we see, and all too commonly, increasingly so, Steubenville is a great example of this for people that remember that situation. There are sexual assaults that are happening in very, very, very public settings, right? And so it begs the question, why didn't anyone intervene, right? And so the part of the Coaching Boys into Men model is one of intervention, of engaging people as bystanders so that they can comfortably reach in and say, you know what, that's not right, or back off, or create some distraction, whatever it needs to be to really disrupt a scenario like that happening. So we're seeing some positive results in terms of decreases in abuse perpetration for athletes. That's here in the U.S., and there's a similar model that's been, it's sort of a spin-off model that's been implemented in India, also with some promising results in cricket teams. So this is a model that I'm hopeful we'll be seeing more and more of, really targeting early adolescents and mid-adolescents as people that have their whole lives ahead of them and are wonderful agents of change in changing our standards around perpetration of abuse, and also changing cultures that allow harassment and perpetration of gender inequitable norms to really to continue.
Okay. I'm going to close with sort of some big questions, but maybe you can think about what you'd like to do next, which is, what research would you like to do that you haven't been able to do, and what services would you like to provide that you have not been able to provide? So maybe like what you're hoping for next.
Yeah.
I think we definitely like to expand our safe homes model, and I would like to see more of the outreach models in place, and see if we can't get a better way to collect the data from that and really help that to inform the work that we're doing. So whether that's through the health clinics, outreach through the health clinics, or outreach through the police departments, or outreach through community-based groups that are in particular communities. I think that idea of getting out there and really trying to get the information about healthy relationships and planting that seed is really where we need to go. The other piece that I think we're very much interested in providing more services around is helping to raise awareness around the effects of domestic violence on children who witness it. Yeah. Too often, people believe that because the child was in the other room, was, quote, asleep, unquote, the child isn't being affected by the domestic violence, and then custody decisions are made around that, visitation decisions are made around that really have very harmful effects on those children, and they're not, if they're not getting help for the trauma that they're experiencing because they're a secondary victim who is helpless to stop what's going on, it's like a trajectory. You can just see where they're going to be in 20 years, and it's not going to be in a healthy relationship. So I think those are some focus for the future that we're really looking to try to expand on.
Okay. Did you want to? Oh, I completely left you out.
Oh,
you have time.
Okay. Well, I think that getting at. I was going to say, a lot of the work that we have in the violence world, in terms of the research, in terms of health impact, and even the intervention impact as well, as it's often very short term. The holy grail is really figuring out, what is the impact of any of these interventions, over 5 years, over 10 years, and these are the things that we really grapple with in the field, I would say, from the research perspective, and certainly an area that I think, we're going to be seeing more and more in the future. And then the other piece is just bringing in some of these really marginalized populations, so integrating some of the work, again, that we're doing with sex workers within a broader sort of GBV lens, and figuring out what are the best practices for gender-based violence prevention and support for really vulnerable groups, women that are involved in sex trade and trafficking and exploitation in any of those ways. The research base there is in its very infancy, I think, and there's a lot of potential and a lot of interest right now in trying to figure out what to do, what are the interventions. A lot of them, unfortunately, to date have been these mandatory services, and that's not working. And so there is a real need for innovative models and also research to really get into that.
Great, thank you. It's time for us to close, and I want to remind people that our next Grand Rounds is March 19th, and that the topic will be on our website soon. And I want to thank the audience, both the live audience and the online audience. I know for the online audience, the sound may have been a little spotty, and so I apologize, and hope you hang in with us. The PowerPoints will be posted probably later today or tomorrow on our website. and the archive of the webcast usually takes about 2 weeks. And I want to really thank you, Janice and Michelle, for putting together not just this incredible presentation, but also a really wonderful example of sort of the interface and the partnership between the academic and the practice and service communities, and by working together, how we can really make some leaps. So thank you both very much.
Thank you. Thanks.